CEO, co-founder of ADHD UK. Hi, so it's really excited to welcome you here. So this is an important segment we're doing on ADHD and pregnancy and ADHD medication and pregnancy. And I'm absolutely delighted. Well, let me introduce you to them. We've got Phil Anderton and Lisa Mangle from ADHD 360 who are here to support us. And if you've got any questions, do post them. So we're broadcasting live on Facebook and YouTube and Twitter and LinkedIn. If you've got questions, post them there. We will be looking at them and coming to them. We've got about 45 minutes. Right, let me introduce you to Phil Anderton and Lisa Mangle. Do you want to introduce yourselves quickly? Tell us just a bit about who you are. Phil, do you want to go first? Tell us about ADHD 360. Obviously, no.
Yeah, sure. Thanks, Henry. And hello, everybody. My name is Phil Anderton, Managing Director and co-founder of ADHD 360. We are a private ADHD provider of services, and we provide under contract to the NHS across England. My background was in policing when I realised the amount of people with ADHD that were untreated or treated poorly weren't getting the social outcomes out of life they deserved. And having pushed for about 15, 20 years for changing the NHS and not getting it, Lisa and I decided to set up ADHD 360 to do just that. And proudly, we are doing that. As Lisa will explain as we go through the 45 minutes, we are incredibly insistent on championing women's rights with ADHD. The theme of today is pregnancy, but there's a much bigger, wider piece of work that we're engaged in terms of understanding women and ADHD and trying to shift the debate away from the distracted woman at the back of the class to the fact that every woman has symptoms and impairment with their ADHD that mirror those of a man and require exactly the same attention and exactly the same intervention. And we're hell-bent on doing that. And proudly, we have 51% of our patients who are female. And that's, I think, evidence that we are removing some of the barriers to access that traditional systems would have. Enough from me. Perhaps Lisa.
Hi, I'm Lisa Mangle and I'm the Clinical Director at ADHD 360. I'm one of the co-founders. My background in ADHD is that I worked in the NHS for 10 years with my own nurse-led clinic. And whilst I was doing that, I was involved in the clinical trials that brought some of the medicines to market, so namely atomoxetine, Elvance and Inchinib. So that got me engaged in that process. I then went to work for one of the companies that make most of the medicines for ADHD as their medic. And whilst I was there, we launched a couple of products, namely Elvance and Inchinib. But my role was to talk about all the medicines, not just the ones that our company at the time made. And then I've worked with Phil on and off for the past 20 years. And we set up ADHD 365 years ago. And the premise really for setting up was that we'd done a piece of work that looked at what a platinum standard service would look like from beginning to end. And at the end of that project, we decided to build a service around what a platinum service would look like. And we've been doing that now for nearly 5 years. And have about 80-ish clinicians who assess many patients per month. I'm proud of that.
Thank you. And it's obviously ADHD 360 is doing extraordinary things, and very biggest in the country. Mm-hmm. And to my view, absolutely, that means doing some of the most good in the country, because you're helping so many people. It's a simple, people getting that support is, usually life-changing. Right, on to our questions. We've got a topic in an important area, so I'm going to introduce this properly. So this is a topic that came to ADHD UK. I had someone come to my drop-in clinic and talk about the fact that they were pregnant, and that they have a child and a job, and that medication is life-changing for them, and that they were very, very worried about what would happen if they said that they were pregnant, if they would find the support of medication removed, away from them, what that would mean. And that's put them into a point of sort of paralysis where they were just afraid, but they were also afraid about, was there an impact of taking medication on their unborn child? And it was obviously something we knew that would apply to other people. And so we set up this to try and get more information to people around this very, very important topic. As I said before, if you've got questions, put them into the chat wherever you're viewing this, and we'll try and answer them. But we've got some questions beforehand, and so I'm going to bring back our two parties. So I think the big question is, can you take medication and be pregnant?
Can I take that one? So because I was involved in the clinical trials for ADHD back in 2020, maybe just before that, one of the criteria was that you couldn't be pregnant and be involved in the clinical trial that brings a medicine to market. So the actual...
Well, that's standard though for every clinical.
That is standard for any medicine, So what we didn't have was the pre-marketing authorization data around pregnancy. But what we do have is, once a medicine's been brought to market, not just ADHD, any medicine, if you're on a medicine whilst pregnant, what the clinician should do at the end of your pregnancy, when you've delivered your baby, is actually let the companies know that this lady's been taking this medicine whilst pregnant, and the baby's fine and the lady's fine. So what should happen if you've got a patient who's pregnant taking a medicine is that you let the company know. So the companies find that post-marketing data and they freely share that data. Now, when you launch a medicine, you produce what's called a summary of product characteristics, and anyone can find that. You can put summary of product characteristics in a medicine, and you can freely see that, and it will then tell you what to do if someone is pregnant or breastfeeding or wanting to become pregnant. And the data for the medicines for ADHD, the stimulant medicines, are if the benefit of the treatment outweighs the risk of taking the medicine to the mum or the baby, then it's okay to treat. So my view is that we take all our patients as individuals and have that conversation about what were you like pre-medicine, what were the risks, what is this medicine doing to you now, and it's a discussion between the lady and your clinician around whether the benefit outweighs the risk. And in some patients, the benefit absolutely outweighs the risk for a variety of reasons, and we can talk about that later if you want to, or I can discuss that now. It's up to you, Henry.
I think it'd be great to hear that now. I think just for clarity, so what you're saying is that that medication whilst pregnant is definitely an option.
Yeah.
That there has been data fed back through the system you just described about medications, the safety with the baby.
The only medicine where that wouldn't be possible is Inchinib. Now, Inchinib isn't licensed in adults, but it does say in the summary of product characteristics that you should, if you're a woman of childbearing age, you should use contraception. So Inchinib is slightly different, which is why I said for stimulant medicines. So for your methylphenidates and your dexamphetamines, it states if the benefit outweighs the risk. But with Inchinib, that's different, but that would be off license in adults anyway.
Why is that different? Like, why is that?
It's a completely different medicine, and in animal studies, there'll have been concerns And also it's only licensed in children in this country, so we're not going to have that wealth of data that we have for stimulants in that post-marketing surveillance, because not many adults will be on Inchiniv, so there'll be very limited data, I would imagine. But for stimulants, that's different. And when I say, does the benefit outweigh the risk? I've got several patients who are pregnant and breastfeeding, and we have that conversation around, so what was it like when you had your previous children? So they'd had, children off medicine, and they found life really difficult, and they found keeping healthy and eating the right foods and attending appointments and taking any medicine that they might need to take, so folic acid, for example, to keep the baby healthy. They found all those things really difficult, and the mental health struggled, and there was a lot of postnatal depression because of that struggle. So when you're having a conversation with a lady who's pregnant and that was their experience in the previous pregnancies, but now they're stable and optimized on their ADHD medicine, and life is so much easier, and I can manage that toddler or my older children, and I'm really scared to go back to that experience, then you have the conversation about, okay, this is what you're saying it was like before, this is what your life's like now. Do you want to continue medicine to keep that life stable and for your health to be optimal and for the baby's health to remain well? That's the kind of conversation a clinician should be having with a patient, because it's a two-way thing.
Thank you. I think that's really important, and thank you for discussing more and the detail around it. How like you said, so there are some animal studies. So is it standard that some animal studies with pregnant animals is done?
They always do animal studies before they do human studies. So in medicine, so they've done those studies before they even gave a medicine to a human.
Right.
And also my having worked in the pharmaceutical industry, they would not put on a document, if the benefit outweighs the risk, treat the lady, if they had any inkling that there was significant concerns, because obviously that's going to come back and haunt them. So, I always look at that and think, okay, they've said that, so they've obviously got that inside information around any risk or not. But it's always the lady's choice. It's their body, their baby, but the information and the advice should come from the clinician who's the expert in the medicine, and it should definitely be, and also liaising with GP. So the lady that you've spoken about, we can liaise with the GPs and have that conversation about the science and the data and how the lady was before optimization, what they like now, and the discussion that we've had as a patient clinician discussion, because it is important that the GP knows, they're your sort of case holder, if you will. So it's important that they've got access to all the information, and I get the worry, I do, because when life's been tricky and now it's not, you just don't want to go back to that tricky time.
Plus an extra kiddo, like it's
chaos.
It's like the more there are, the increase the challenge.
What's more important is that the lady is looking after herself, looking after the health of the baby, turning up to appointments, managing food and eating regularly and keeping themselves hydrated and well. That's equally important to the baby. So you've got to look at both sides, and it's not just, oh, I'm pregnant, it's, let's stop everything. It's about, let's look at the whole picture and communicate.
And so one of the other questions we've had is, should I stop taking medication prior to pregnancy, which I think if you're taking in pregnancy, the answer's there. But can I just confirm that with you?
So again, that's a conversation. It's something that we always ask our patients. You know, one of our risk questions is, are you planning a pregnancy? Are you pregnant? Are you breastfeeding? So again, it's a conversation that I would have, and it would be the same one. Does the benefit outweigh the risk? Because we all know that when you find out you're pregnant, you've usually been pregnant for 4 or 5 weeks. So it's better to have that conversation before you even consider getting pregnant. So if you're stable and optimised and you're in shared care, that is absolutely a question to go back to your clinician and say, this is what I'm planning, and have that conversation and feel confident that you've got that level of support. So it's exactly the same conversation It's a slightly different conversation, breastfeeding. I don't know whether you want me to go into that now, but it is for me, it's a very different conversation if a lady's breastfeeding. So
I can juggle the question list up. Like, so yeah, that is a question that's been asked.
Yeah. So for me, breastfeeding is slightly different because you've got a newborn baby who's not established on breastfeeding, and there is a 10% chance that the stimulant medicines do transfer into breast milk, about 10% of the medicine. So obviously there is a different concern if a lady's breastfeeding. So again, that's a conversation I have whilst they're pregnant. You know, are you considering breastfeeding? You know, have that conversation now without any pressure or judgment. It's a lady's choice. But my slight concern about medicine and breastfeeding is, will it impact on the baby? And I actually would prefer the baby to be an established feeder and gaining weight and sleeping in a pattern before treatment is introduced. And I say that with a fair bit of experience. And to be fair, I've only had one child who sleep was impacted when we went up to a slightly higher dose of a medicine. And again, it was I think they were about 14 months, but they were an established feeder. But the sleep was impacted when we went up to the higher dose. So again, it might not have been that. They could have been teething, I'm not sure. But we just brought it back down a dose and they were fine. So I need the newborn baby to be an established breastfeeder, gaining weight, sleeping in some sort of a pattern before I'm happy for the lady to feed. And so I have a range of people who choose to not breastfeed because I don't want to have that chaos of not having treatment when I've got a newborn baby and maybe a toddler and getting used to that. So that's their choice, but it's an informed decision. Or I might have a lady who, you know, decides to come off meds for a month or so, and then we have a follow-up appointment and have that discussion and see where she is, see where the baby is. And I might ask them to get the baby weighed more regularly, you know, and go to sort of health visitor drop-ins for weight. And then when they're happy with the baby and I'm happy, we'd then restart medicine and optimize that. So again, it's an individual decision, and it is definitely a clinician-patient decision. And as I say, I've had a variety of ladies who've decided not to breastfeed or stopped breastfeeding after a few weeks, or actually kept breastfeeding and continued medicine. We'd have more regular follow-ups, and I would want the baby to be seen more regularly. But, you know, and even when they're established back onto breastfeeding and medicine, they would still be followed up every 3 months just to make sure that there isn't an issue. And the way that we work at 360 is they'd automatically be high risk because they're either pregnant or breastfeeding. So that means they get more follow-ups than other patients.
on this topic, can I ask what's the differences? So you've got the mother taking medication, and then I assume some medication being transferred, like being passed to the baby through the placenta, and then you've got the same but through breast milk. But for breast milk, you're at a like we shouldn't be mixing, and for placenta, you're okay. Could you just elaborate on why there's a difference?
I think when you're breastfeeding, you've got a baby in front of you that you can see. So, you know, the side effect profile of stimulant medicines that I would be concerned about in a baby are appetite and sleep. So what you need is for a baby to be feeding well and growing and sleeping. Well, we know babies don't sleep, but sleep in a pattern that is established. So to be fair, I've never had a lady with a newborn baby, or, you know, an under 6-month-old baby who's been breastfeeding and had any problems. You know, my follow-ups are different because I'm asking about the lady and I'm also asking about the baby. So, but what I'm asking about the baby is, are they feeding well? Are they sleeping well? And are they growing? Are they putting weight on? And so you can, you know, you've got that baby there visually, so you can, and usually they're on the follow-up, so I can hear them and they're usually feeding at the same time. So it's a lot easier to monitor any impact on the baby when they're breastfeeding. But I would want them to be established, because it's nothing more stressful than trying to breastfeed a newborn baby and having that worry about whether the medicine that you're taking is impacting. Does that answer your question?
It does, and it's great. I'm really pleased to have asked it, actually, because I think that core on like the side impacts of the medication are things that are incredibly important to a baby in terms of sleep and weight gain, and therefore those are not issues when they're in the womb.
Yeah.
And that being very different. So I think, yeah, that's fantastic. We had some more general questions, and one was like, are there any supplements? So when someone's pregnant, they're taking folic acid and looking very carefully at diet, so are there any supplements that might mitigate any negative impacts of medication? You know, do I lose more minerals or vitamins, for example?
So not that I know of. So from a supplement perspective, ladies can take the supplements that the midwife would recommend. There's no concerns around that alongside their ADHD medication. I know you mentioned vitamin C. So that there's quite a few people who say don't take high dose vitamin C alongside your ADHD medicine, and I don't think that has been thoroughly researched. I think it's anecdotal information, and it will be around absorption. So it will be around, are the medicines absorbed as well as they might do if you're taking high dose vitamin C. So I would say
there's no evidence on vitamin C.
There's anecdotal evidence of people saying, if I have high vitamin C tablets and juice and what have you, that a medicine doesn't seem to work as well. And sometimes, acid can impact on absorption. And they have done studies.
Vitamin C,
they've also done studies looking at the opposite, where they've given a proton pump inhibitor alongside ADHD medicine, so an omeprazole or a lansoprazole, to see whether that impacts on absorption. So they've done that, and it doesn't, but it's anecdotal evidence with vitamin C. So I would just stick to what you normally do when you're not pregnant. Okay.
And the reason I wanted to bring up, and thank you for doing it, vitamin C, was obviously there is this discussion going on, and vitamin C being absolutely critical in terms of healthy immune system and a healthy body. Phil wanted to come in, so I just want to bring him in on talking about the balance of risk on medication.
Yeah.
So Phil,
Thanks, Henry, and well done, Lisa, with a very pragmatic set of answers there to a very complex situation, I think. But the complexity has to be seen in context, doesn't it? Whenever we're dealing with medication in any spectrum of health, ill health, and life, we're always going to be balancing side effects against risk. And we've just come from an academy training new clinicians joining the organisation. One of the big discussions we have is about managing that risk. And I think Lisa's point that was made is worth reinforcing, Henry, and that is, if the risks of not being treated outweigh the potential risks to the unborn baby, or indeed the breastfed baby, we have to put controls in to manage those risks. And one of those controls may well be the use of appropriate medication with appropriate monitoring. And we find all of the time our patients being nervous about ADHD medication, regardless of whether it's specifically about pregnancy or not, but obviously nuanced for pregnancy in this context. But we must always look at, and Lisa made the point about managing the overall risk of mum. And if mum's life is going to go back to some form of unmanaged, perhaps someone may say chaotic, difficult to manage, where folic acid might not be taken, appointments won't be kept with the relevant medical support through the pregnancy, we really have to balance that risk against the risk of taking the medication for the unborn child. And your clinician should always help you managing that risk with absolute guidance on the outcome of that discussion about that risk. And I think we would make the point individually as humans, but as an organisation, that your clinician needs honest information from mum and any other informant relevant to that lifestyle on how that risk profile manifested pre-medication for ADHD. What drove you to be treated for ADHD? Let's go back in time to what life was like before, because if we take you off medication now that you're pregnant, or indeed breastfeeding, that's what it could go back to. And what coping mechanisms need to be put into place to see if that's safe for both you and the child. And if they're not going to be adequate, then we have to look at how we're balancing that risk and closely monitoring things. And I think sometimes the debate over medication, yay or nay, loses sight of what we're actually doing when we're treating someone for ADHD in the round initially. And that is trying to get those impairments and symptoms that presented that caused the patient to go into service in the first place. And we should be very wary of returning to those without due consideration. That's the point I'd make, Henry.
Thank you. Thank you very much, Phil. I think that was great. On medication, one of the other questions is, are there any interactions I should be aware of, or particularly the mum should be aware of? So, for example, going into labour and talking to the midwife, what should be said and what should be kept an alert for?
So my advice is to stop the medicine when they go into labour, because obviously as soon as they've had that baby, they're likely to be breastfeeding. So that's always been my stance, is to stop your medicine. Obviously, if you've already taken it that day, then you've taken it that day, and there's nothing you can do about it. As much as I'm aware, I don't think there's any known interactions with any medicines that they might give you during delivery. But again, that's something that you would need to let your midwife know, or an anaesthetist, for example, when you go into hospital that you've taken, what medicine that you've taken, but they should ask that anyway. You know, they're going to ask that about any other medicine. So if you've gone into labour and you didn't realise you were going to, then you've taken your medicine, and that's that. But I wouldn't then take any more until you've delivered and decide what you're going to do about feeding.
And then the question that's at the start of all of this, does medication affect the ability to get pregnant, and also for the man, like, does it affect their sperm at all, like, in a sort of exaggerated way, like, you know, is their sperm contaminated or impacted in some way?
Do you know, that's a really good question that I don't actually know the answer to. I suspect it's not been studied in humans, but I am going to go away and find out, because I don't know the answer to that, and it's not any advice that I've ever.
I regret combining both questions now. So one was about the woman getting pregnant, the other was about the man.
Yeah.
So
I mean,
is it the same answer for both?
I've looked after ADHD patients for 22 years now, and I've, you know, I have had some ladies who've struggled to get pregnant, but for other reasons. I've never, you know, I can't say that I've come across a larger group who've struggled to get pregnant than the general population, but I'm not sure that data's available. But I'm going to go and have a look. I'll let you know next time.
That sounds great, thank you. I presume that's the same answer for the men. I don't know, not been studied.
I'll go and find out.
Yeah, and and to be clarity, that's not just a really good science answer, which is that, like, I'm going to go and find out and learn more and give you a considered answer rather than just going. And so the absence of an answer does not mean, therefore, it's automatically terrible things. It just means
no, just I've never had the question asked, and I've never thought to look. But I'll go and find out.
And then I think and I'll just check in our group, see if we've had any additional questions to the ones I've asked. You've been doing the answering. Anything else around this topic area of pregnancy that you think?
I think one of the things I've not mentioned that I think is really important is that if you are pregnant and taking your treatment for ADHD, I probably would want more regular contact with your midwife. Having got a daughter who's pregnant at the moment, and contact with midwife is pretty minimal these days. So I would want to know that your baby's growing well. So more regular contact with your midwife would be what I would advise, and I'd liaise with your midwife if required. But just keep in touch with people and just let them know how you're doing. And we do have some ladies actually who find that they don't need quite as high a dose of medicine when they're pregnant, and I suspect, although I don't know scientifically, I suspect that is because the estrogen level when you're pregnant is much higher. So some of my patients whilst pregnant need a slightly lower dose, and that's fine. And then we'll reassess post delivery when the hormone levels are back to normal. So that's one thing I've not mentioned, but I thought I would. Phil, I think you wanted to come in with a comment.
Yeah, there's been a question on LinkedIn where someone's talked about the male libido being impacted.
Yeah, we some of the medicines, and Lisa's going to give you the detail any second now. I'm almost warming her up for that. Is that with some of the medicines there is a side effect for men in terms of erectile dysfunction. And that can be obviously very disconcerting. And we know we've had patients with that known side effect of certain medications. And maybe the questioning about the performance of sperm may actually be linked to the libido question and ED. And I think that's where Lisa could just discuss those particular medications, perhaps, because that is something that we've dealt with in the past.
Yeah. So it's generally with stimulant medicines, although it can occur in the non-stimulant group as well. And what I tend to do, if this side effect occurs, is obviously ask the question, does the benefit outweigh the risk? So again, some guys are happy to continue with the treatment and suffer with the side effects, but it's a very patient specific decision. I have actually switched to immediate release preparations in quite a few cases. So rather than having a long acting medicine where once you've taken it, it's in the system for the next 8 to 12 hours, use an immediate release version that might last 4 hours. So then you can choose to take it not at all, once, twice, 3 times a day, but you've got a little bit more flexibility so that you can choose not to take your medicine at a time when you might need to not have erectile dysfunction, and this is really important, and it's an area that guys often don't like to talk about, but it's a really important area of life, and there's things you can do to manage that. So it's important that if you're struggling with that side effect, speak to your clinician, and there are things they can do that might minimize the side effect.
Thank you, and I think thank you for talking about that. It's an important discussion area that's often not talked about, and people struggle to talk about. So thank you. One of the side impacts on medication is people often talk to is blood pressure, and hypertension in pregnancy is also quite common.
Yeah.
How does that? Do you find that impacts the medication discussion?
I think that's a really good question. So whoever's asked that question, well done. So I think it's important to think about hypertension as a medical issue, but also as a potential side effect issue, and then we've got the added, hypertension in pregnancy, preeclampsia. So my suggestion would be to take your blood pressure regularly. So for those who aren't pregnant but considering pregnancy, take your blood pressure regularly every week, document it so you know what your norm is. But you've also got to think about what may cause your blood pressure to raise. And if you don't take your treatment and you're pregnant and life's chaotic and you're not getting jobs done and your existing children are hungry and you've not got any food in the fridge, then your blood pressure is going to be up. So, not treating your ADHD can have a real detrimental impact on blood pressure. So you've got to really know what your normal blood pressure is and monitor it. And stimulant medicines are known to put your blood pressure up by 5 millimeters of mercury and your pulse up by 5 beats per minute. So we know that. But it's really important that you do your blood pressure regularly. We provide a blood pressure monitor at ADHD 360, but if you don't have one, go get one or have it done at your pharmacy or your GP surgery. Just, but know what your normal is and take it regularly. And I'm doing the health promotion now. If you're not pregnant or breastfeeding, do your blood pressure twice a year, on your birthday and at Christmas or whatever you celebrate, so that it's just a reminder. It's really important that you do it at least twice a day, even when you're stable and optimized and not pregnant.
Phil wants
yeah, Lisa's very succinctly there talked about pregnancy risk of hypertension and medication in that scenario, and that's exactly the theme for this webinar, and it's really important. But what we also don't want to do is set hairs running. That there is a danger of hypertension from ADHD medication, because what we find, we assess over 1,000 patients a month, and what we've actually found is we're finding more people who were hypertensive when they've come to our clinic but were not aware that they were hypertensive than we are finding problems with medication and hypertension as a result. So Lisa's health promotion piece there is extremely important. We should all know and monitor our BP and pulse, regardless of anything else. And some of the case studies we've worked with and produced over the years are we've actually managed to reduce people's BP and pulse through effective use of ADHD medication, where their anxiety that's caused high BP has actually been caused by their untreated ADHD. So there's a flip side to the coin, and we wouldn't want to set any hairs running that ADHD treatment equals stimulant medication equals hypertension, therefore you've got a higher risk, because that's not the case. There's a difference between slightly elevated and hypertension. And that's why we monitor BP and pulse regularly. And as Lisa says, we give every single patient their own BP machine to have at home and keep, so that they can send in their readings regularly. And it's really important to recognise that on the scale that we work at, we're part of a national study of BP and pulse amongst the patient population that's never been done before. And we don't see the indices of increased risk that perhaps some commentators would have you believe just because of stimulant medication. And I think it's important we give people confidence in that regard, as opposed to when by discussing it, we do the opposite and take away the confidence of treatment for ADHD, because it's vitally important to treat those risks. And we don't see the subsequent risk that some would say you would get from stimulant medication and hypertension.
And I think one of the other things to talk about, I guess, with pregnancy is weight. So off treatment, a lot of my patients are morbidly obese. So only last week I supervised 2 assessments, and they were of a 30-year-old and a 31-year-old whose BMIs were 40, and they were pre-diabetic and had both had gestational diabetes when pregnant. And so if you don't treat your ADHD, you are more likely to binge eat and more likely to be overweight or obese. And then you add pregnancy on top of that, and you've got a high risk pregnancy because they started obese, and there will always be a high risk pregnancy if they start obese. And then if they're off meds and they're more likely to binge eat while pregnant, that weight's just going to go up and up, and that's really putting the lady at risk. So I think it's not just about thinking about their ADHD symptoms, it's about those other things that come along, like Phil said, hypertension and binge eating and all the risk that puts a lady on and the baby through if we don't continue to treat their ADHD whilst pregnant.
Thank you. That's really important. Right, no, we're at terrible risk of running to time, which always feels wrong for an ADHD. I think we've done a good job of answering the questions as they've come in. So obviously we had before. I think we've had some from other topic areas, so we'll probably need to try and come back on those. This has been fantastic. Thank you so much, both of you. Thank you for ADHD 360, but being the host of this with both of you. It was great actually to hear about that national study that you're being part of, that study's happening around blood pressure, and that obviously your extraordinary numbers are contributing serious data to. Do you have any final wrap-up words?
Speak to your clinician. I would say don't be worried about the medicine and pregnancy. Have the conversation, and if the benefit to you outweighs the risk, have that conversation with your clinician, and please don't be scared to have that conversation with your GP as well.
Yeah, and that core message that it is a sensible conversation about managing risk, but understanding that medication is absolutely an option. It's been done and reported on as a part of medical post-marketing trials, and that it is an option. So for the person I spoke to who was worried that the rug was just going to be whipped out from underneath them, that's just not going to happen.
I would just get, if I can, Henry, last words from me to make sure you don't finish on time and you stay true to yourself.
Yeah, we are. We're now.
If you look at it in the round, the conversation that we've had, the fantastic conversation we've had today, this is about pre-planning for pregnancy, and that pre-planning will only be truly effective for a person with ADHD when they're being treated for their ADHD. So the pre-planning has to occur before pregnancy planning, if at all possible. And there's more chance of pregnancy planning if the lady with ADHD especially is being treated for her ADHD, there's an incredibly high risk. Russ Barkley puts it about 47 times higher of an unwanted pregnancy if a lady isn't treated for her ADHD. So the overall message has got to be, stay with your treatment, plan your life appropriately, act accordingly, and then speak to your clinician and make those decisions as you move into that next phase of your life. Obviously, not every pregnancy is planned. We get that, we understand that, and that's where you'd need to move quickly to get sound advice. But as much as possible, stay on your treatment, plan your life with the skills that the treatment gives you, and then act accordingly with your clinician.
And just to be clear, obviously, this is very much focused on medication because of the questions and the conversations around that. But obviously, medication isn't in everyone's treatment plan, and to say that that's not an obligatory part. I just want to add that clarity. Guys, thank you so much. So, Phil and Lisa have donated their time, it's very kind of them to do it. Shedled and answered all the questions thrown at them. It's been wonderful. I just want to thank you both very, very much, and to thank everyone for watching. If you didn't catch live, or for those that you want to tell people about, the videos will remain on our social media. So they're on Facebook, on YouTube, on Twitter, on LinkedIn, so you can catch up with them again. Obviously, we're a charity. I have to do the bit where I say, like, we get no money for government. Please donate. Please fundraise for us. It's the only way we can do what we do. So thank you. But for today, for their knowledge, for their expertise, for all they're doing, for being here and answering questions, thank you so much, Phil and Lisa. It's just wonderful. Thank you.
Thank you.
All right, bye guys, and bye everyone else. Thank you very much. Bye everyone. Thank you very much for joining. We will do more of these, and don't forget we've got the global conference coming up, which is our 24-hour conference on the start of October, and you'll hear more about that from us. But that's Phil and Lisa were part of that last year. They promised to be part of it this year as well, which is great. We're going to have many people. We've already got a good chunk signed up. We're excited to be bringing that to you. Have a great rest of your day, and thank you for joining. Bye-bye.